We're going to start with the first week slideshow, and I'm going to each week do a YouTube upload to have additional information that will help you with your Masters of Healthcare Administration for the Healthcare Quality 575 class. This is Sonia Reback, and I'm your adjunct faculty for this course. I do want to reinforce, since we're not meeting live, that I am just a phone call away, email away, or text away. I am very prompt about looking at my text messages as well as answering calls. If I'm at work and I can't take your call immediately, leave me a message and I will get back to you as soon as I can. Most of the time in the evening I'm pretty available, so again, don't hesitate if something comes up and you have a question to reach out so that we can get you some answers. My cell phone is 812-230-2798, and again, please let me know if you do have questions. Okay, I wanted to just go over a few items that I think globally with healthcare quality we need to be thinking about. I think sometimes we get really tunnel vision with looking just at hospitals when we need to think a lot broader when we think about a healthcare administration role and what it does mean with healthcare quality. So first, of course, the acute care hospitals, that is an obvious one. We also have our critical access facilities, we have our urgent care, we have extended care facilities, we have home health care, and again, now they're starting to use the trend of calling what they did call home health care into a health care at home. So you may be seeing a transition into that terminology. You have your hospice care, physician offices, and there's so many others. I know on many of the different initiatives now that they have to prevent harm and with antibiotic stewardship, they're also including dental offices. So again, really do think broad when you think about the various settings for healthcare. Healthcare quality, again, some reference sites. These are good just to be aware of. They're good links to go to for some solid information. First one, you'll hear it called CMS. It stands for the Centers for Medicaid, Medicare Services, which is basically our federal government. Next is your state organizations. I'm going to use the example of Indiana State Department of Health. Obviously, that's one that we use a lot here in Indiana. But any state, you can go onto the internet, pull up their information, and be aware of what their regulations are as a reference for you. Also, there's the Agency for Healthcare Research and Quality. They go by the acronym ARC. There is the OIG, and that is the Office of the Inspector General. The QIO, which is the Quality Improvement Organization. The QIN, which is the Quality Improvement Network. And I didn't add it on here, but there's also QSource, which is again tying in with the QIO and the QIN, which is a collaborative around several states, again pushing CMS initiatives out to the public and to healthcare facilities. Federal and state accreditation, the entities that are involved for a facility getting their state licensure, getting their accreditation, their annual surveys. CMS, obviously, they can come in and do their own standalone surveys. Many times they'll depend on the state that will also come in, but they will look at the facility from the state regulatory component, but then also the federal, which is the CMS. It's not to say that the CMS can't come along and do their own standalone survey, but usually they will rely on subcontracting with the state to do that. The Joint Commission, when they come in, they also are looking at a broad spectrum of the regulatory, so they'll be looking at their own regulatory components, but then they will also look at the ones for the federal government. Do note the year that you have a Joint Commission survey, if you're in, example, the hospital, that year the state will not be surveying that hospital unless there is a complaint, and they can still come and survey for a complaint situation, but they would not come in and do the annual survey on the same year as a Joint Commission survey. Another surveying body is HFAP, and that's the Healthcare Facilities for Accreditation Program. And I know that that too is used, getting more use across the nation. So again, Joint Commission and HFAPs are the two that I hear the most. You're going to hear a lot about healthcare transparency. That's not a bad thing. Whatever we report tends to get addressed, and we want to do better. It also helps the consumer to know what area a facility may have deficits, or maybe where their opportunities lie. It's also very good internally in an organization to know where your strengths are, where your weaknesses are, or gaps, so that you can then address those. So a few that come to mind: Hospital Compare. You can go to their website, and you can go in and you can compare different hospitals across the nation. So you can compare East Coast, West Coast, and everything in between to see how a local facility compares maybe with a facility in a bigger hospital or across the nation. Health Grades is another good resource. Your state reportable events. Not every single state has reportable events that are required to be reported. Indiana is one of them. So they release that information. It's usually a little bit older information when it's released. But again, that is a good resource to kind of get a pulse check on if an organization has a solid process or not. And one other one to mention is Leapfrog. Leapfrog, they do actually a two-prong approach. They have an annual report that facilities voluntarily can contribute information to, and they do that usually in the spring, and it usually has a deadline of around June. From that Leapfrog information, that can be updated anytime during the calendar year. And from that, they have a fall and a spring grade release. And so they're grading a facility much the same as if you were getting a report card if you were at school. So A, B, C, D, that kind of thing. A is the best. Obviously, that's the goal that you wish to achieve with trying to have a good gold standard. This sprung off of some practices with state surveys in California, and they were doing surveys of restaurants and giving them a grade and putting it in the window, so that way consumers would know if they wanted to go to that restaurant to eat, is it a good restaurant? Does it have a good safety rating? That kind of thing. So Leapfrog is a voluntary consumer group, and they came up with this same notion that let's do this with healthcare facilities, and it is going to give the consumer a little bit better idea, as well as insurance carriers, how that facility function is it a good place to go. So again, it's based on a lot of safety endeavors, prevention of harm events. So again, it gives you a good pulse check. Healthcare information privacy and confidentiality. This is, of course, very important. HIPAA, which is the Health Information Portability and Accountability Act. This came into play with the U.S. Congress, signed by President Clinton in 1996. There is further information on the HHS.gov website, so Health and Human Services. Also the CARE Act. So January 2016, this actually came to be a new Indiana law, and they were adding requirements for patient admissions and discharge procedures, and this is helping to get information out to maybe a lay person who's going to lend support to a patient, and that patient can delegate them as a care provider, and then that will allow the staff to also share discharge information with the patient, with that chosen care provider, as well as with other advocates for that patient's care. Ransomware. Again, we got a lot of cyberbullying that you'll hear about from time to time. I think healthcare organizations, I think businesses, I think anyone using electronic means has to be aware that there's always some people out there that are trying to find a way to scam or to crash into a site, maybe hold electronic information at ransom for a facility. So hospitals and any healthcare facility is also vulnerable to that. So you will see a lot of the IT folks sending out regular information, trying to keep all the healthcare providers educated as to what to look out for. It really is a need to know. So when you're in a healthcare setting, if I'm not directly involved with a patient care situation, if I am not directly doing something with that patient's information, whether abstracting it and putting it into a website to upload for data comparison or a data repository, it's really none of my business to be going into a patient's chart unless there is that true need to know. So again, protecting that patient's privacy. Not only do we have to protect it ongoing in general, where we don't have private information exposed on units, on whiteboards, on documents that are laying face up, but also, on computer screens, all these various areas. Just always be thinking about, when you're in a healthcare setting, is there information that is exposed that really I don't need to know that? And if I don't need to know that, maybe someone else walking by does not need to know that as well. So it might be a situation where you want to go to using initials of a patient and not using full names. So again, take inventory of where you work, keep that in mind. Let's keep the patient's privacy sacred. The other thing is, when you're at waiting areas, registration areas, the sign-in forms, again, I could sign in and I might be able to see, 10 names up from mine that, oh, my neighbor's in here. Well, heck, I wonder what's going on with them. Why are they being seen? So again, it's that need to know. So you always need to be thinking about, is this a good process? Are we protecting the patient's privacy? Is there something we could do different to better facilitate that? Just something to ponder. There is the evolution of total quality management, and this is where we get into a little bit of the history with quality. So total quality management, also known as TQM, it actually was coined by the Naval Air Systems Command, and it was its Japanese style management approach to quality improvement. They used an umbrella methodology, and they were always looking at continually improving quality of all their processes. And they would also draw from principles and practices. So they would look at behavioral sciences, analysis of the quantitative and the non-quantitative data, looking at economics and the theories tied in with that, and also process analysis. So in the 20s, some of these first quality management seeds that came into play came into the U.S. industry. So you had businesses, and they were clearly separated from the process of planning and carrying out a plan. You started getting some union opposition, and the workers getting involved with that and wanting, their voice heard about working conditions, functions of their job. It was also in the late 1920s where Hawthorne experiments were conducted. And again, it was showing how worker productivity, it could be impacted by participation. So again, just kind of an interesting twist on just that evolution of total quality management. In the 1930s, Walter Schuhart, he developed the methods for statistical analysis and control of quality. So again, another big name in the quality world and the evolution. Then we flow into the 1950s, and we had a lot going on in the 50s. We had Deming, we had Geron, we had Feigenbaum, we had Crosby. So Deming, he was teaching statistical analysis. He was teaching quality of control, and this was to the Japanese engineers and executives. And again, he can't be considered the origin of the total quality management, or at least a significant tie-in with that process. You also had Duran, who taught concepts of controlling quality and managerial breakthrough. You had Feigenbaum's book, Total Quality Control, and it also was a forerunner for presenting and understanding total quality management. You had Crosby going in there with zero defects, and he was paving the way for quality improvement in many companies. So again, just always trying to push the envelope. How can we do something better? How can we strive for no deficits, no problems, zero fallouts, and going in that direction? 1968, we had Japanese going with approach and again total quality, company-wide quality control. It was around this time that the term quality management systems actually came into play, and you had Hishikawana's synthesis of philosophy, which contributed to Japanese and their quality leadership as far as going in that ascending order. Today, we still hear total quality management. It's more of a philosophy, it's more of a broader approach, a systemic approach to managing organizational quality. Depending on what industry you're in, there's quality standards also tied in with the ISO 9000 series. I see that a lot of times on trucks as you see them on the highways, on the semis, sometimes more in the industrial side, you'll see as far as the ISO. And then also the quality award programs and the Deming Prize, the Malcolm Baldrige National Quality Award, which many organizations have been given because of superior quality care. And it really is tied in with specific principles and processes that comprise total quality management and support that ongoing quality improvement. So, again, looking at the origins, looking at the total quality management, the philosophers that led us to where we're at today. So we talked a little bit about Deming, and he was an American engineer. He was a statistician. He was a professor. He was an author. He was a lecturer and management consultant. He really was an overachiever. He coined the famous 14 points. Originally, this was presented in Out of the Crisis, and it served as a management guideline. So it nurtures more efficient workplace, higher profits, and increased productivity. He also created and communicated to all employees a statement of the aims and purpose of the company. So getting everyone looking at the same direction. What is our mission? What are we trying to achieve? Everyone's on the same plate and looking at the same initiatives to drive the company productivity. He said it is not enough just to do your best or work hard. You must know what to work on. So again, you got to have that vision. So he really was a directional leader with pointing us down that path. He also was talking about working to constantly improve quality and productivity. And this is certainly something that we've held to this point in time today. He also instituted on-the-job training. So again, getting that skill set built up within the workforce. Teaching and institute leadership to improve all job functions. He wanted to drive out fear. He wanted to create trust. He wanted to strive to reduce intra-departmental conflicts. So again, having a cohesive work environment, cohesive work situation. He wanted there not to be extortions of the workforce. Instead, he wanted there to be a good system of morale and positivity. So again, removing those barriers, he felt like that would rob people of pride of workmanship. So again, he really wanted to improve the work system, have positivity, have good trained facility staff so that they could really shine and rise above. So he would really educate with self-improvement programs, and he would include everyone in the company to accomplish the transformational direction. Ishikawa, he was also a Japanese organizational theorist, professor at the Faculty of Engineering at the University of Tokyo. He was noted for his quality management innovations. Quality improvement can always go one step further. So we could always do one step better. Continued customer service. Quality improvement is a continuous process. He also is coined at helping with the cause and effect diagram, also called the Ishiquana or the fishbone diagram, which we still use very much today. So he was looking at what are the root issues, what are the root of process, what are the root causes. So again, many of his tools were very instrumental and still utilized. He really was very much into quality control tools. So many of the charts that we use today, whether it be a control chart, a run chart, histogram, scatter diagram, Pareto chart, flow chart, these all he was contributing to these tools. We will talk about more of these tools later on in a future week. He also really addressed the top level leadership and management support. So again, if you've got good, strong leadership, managerial support, that's going to feed down to your staff. You're going to have better quality, you're going to have better education, you're going to have better lines of communication, positivity. He stressed it takes firm commitment from every single level for the employees to really succeed and for the company to succeed. He believed in setting standards, so he was constantly evaluating and changing if needed. He added a couple more steps to what Deming had set up for the PDCA, which is the Plan, Do, Check, Act. And again, he just emphasized a little bit more structure. So one thing we will talk about at the end of today's YouTube is just the PDCA and how we're going to use that for your final project as well. Duran, he was a Romanian-born American engineer and management consultant. He was an evangelist for quality and quality management, and he had written several books about the subject matter. He was the first to incorporate the human aspect of quality management, so that top quality management or top management involvement, widespread training in quality. He established an institute, and it was a leading quality management consultant from this institute in the world. So again, very instrumental in his work with quality. Shewart, he is known as the grandfather of total quality management. He was a former Bell telephone employee, and he was a teacher of the W. Edwards Deming philosophy. He created the statistical process control process. I know we see a lot of that in stats, also in Lean Six Sigma. He developed the Shewart cycle of learning and the improvement cycle. So again, kind of another twist on that Plan, Do, Study, Act. And also he believed the lack of information hampered the efforts of control and management processes. So again, getting the information out there can really help with improving your practices and improve your management style with processes. Okay, so quality, healthcare quality coalitions and insurers. I talked a little bit earlier about Leapfrog as being a transparency area to get information about healthcare providers. It did come into existence in 2000, and it's by large employers and other purchasers. And the Leapfrog Group is a national, not-profit organization driving a movement for giant leaps forward in quality and safety of American health care. So again, very much an advocate for the consumer, but also doing this as a purchaser and as being a large employer. Other organizations that again are striving to improve where we're at with quality, transparency, and making improvements in our healthcare industry include Anthem, Blue Cross Blue Shield. They have many hospitals that contribute information annually for an annual report. They are looking at that information. They are gauging where we have weak points, so then they can better help provide change or to give information. They are actually changing their system of reporting as we speak. They are now going to more of a quarterly data entry, so more concurrent information to be shared with Anthem for their quality review process. Also, there's regional and state patient safety coalitions. I know in Indiana we are in Vigo County and the surrounding counties, part of the Central Southwest Patient Safety Coalition. There's also a Central Southwest Indiana Organization of Nurse Executives, which also ties in with many safety parameters and information sharing and mentoring with each other. And then there's also hospital engagement networks. They actually are starting to change the title of the hospital engagement networks, and now it's called, it's still the initials of HIN, but it's the Hospital Innovation Improvement Network. These started back in 2012 with CMS and the Agency for Healthcare Research and Quality. They were hoping to make improvements to help decrease harm for patients, decrease readmissions, and strive to reduce cost from the healthcare industry for Medicare and Medicaid, for example. So CMS was very vested in what can we do to drive costs down, but improve patient care and improve safety.